As she rolled in, I immediately was like, this kid is really sick. They were bagging her. She wasn't moving around, wasn't responding. And I noticed too, when they were bagging her, I wasn't seeing a lot of chest rise. And so I was automatically concerned that she wasn't getting ventilated. I knew we needed to get her a definitive airway and get her some oxygen right away.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Welcome back to the show. Today we're diving into a case that is both clinically complex and emotionally powerful. I'm joined by Amber. She's an experienced ER nurse and clinical educator. We're talking about pediatric drowning and a patient that she actually cared for. So in this episode, we'll walk through the events of her day, from the patient's arrival to the resuscitation efforts, and use Amber's story as a springboard to teach the pathophysiology of drowning, what happens at the alveolar level, and how pulmonary edema develops in these cases. We'll also cover the nurse's role in early recognition, intervention, and ongoing assessment. And just as important, I hope to take some time to talk about the emotional toll of caring for pediatric patients, especially when the outcome is a fatal drowning. These are cases that stay with us, and Amber's perspective as both a bedside nurse and an educator will help us think not only about the science of drowning, but also the humanity of nursing. So before we dive in, let me introduce my guest, Amber. Welcome to the podcast.
Thank you so much. Thanks for having me.
Oh, so glad you're joining me today. Can you just briefly share a little bit about your nursing background and what you're up to in nursing these days?
Sure. I've been a registered nurse for about 13 years. Started on med-surg and found my way into the emergency department where the chaos and the teamwork and the collaboration just kind of pulled me in. And I said, this is where I need to work. So I've been in the ER for about 10 years, have done some time as a clinical educator, and went back and forth, was a clinical educator and then moved to a different area where I went back to the bedside for a few years. And I'm now just recently back as a clinical educator in the emergency department. So really enjoy teaching new nurses and experienced nurses and just helping people understand pathophysiology and our treatment and why we do things. It's so rewarding on even a more advanced level than taking care of patients, which is, rewarding in and of itself. But to be able to train nurses to do that is just amazing. So I love my job.
It really is.
It's so fun to see people learn and grow.
Awesome. Well, we're be two peas in a pod today because I'm with you, Amber. I love being a nurse and I also love teaching people about nursing almost just as much. So let's do it together today.
Yay.
Quick note on terminology. Terms like near drowning or secondary drowning or dry drowning are outdated. Mm-hmm. The accepted definition is actually pretty simple. Drowning is the process of experiencing respiratory impairment from submersion or immersion in liquid. The outcomes are classified as either fatal drowning or non-fatal drowning, with non-fatal cases ranging from mild to severe impairment. So that's the framework that I want to use for today's conversation. So let's do this, Amber. Can you take us back to the moment that you first learned this pediatric patient was coming in?
Sure. Well, my assignment just happened to be one that included our critical resuscitation bed. So in the ER, we kind of have two main beds that are bigger rooms and have all that, more critical equipment and, just kind of more set up for those patients that come in, whether it's a cardiac arrest or a stroke or anything like that. And so my bed was open. So I knew that I was going to be the lucky one, that if we had that patient come in, she was going to end up being mine. So when our pre-hospital radio went off, and I know there's people watching probably from all all areas and might not know, the place that I work at is a base station. And so we do get the pre-hospital providers will call in and a certified nurse answers that radio and kind of can give orders and things like that. So the radio went off. And usually when that happens, I know it's going to be a pretty sick patient coming in. So I kind of walked back to the radio room and listened a little bit. And I heard that it was about a 2.5-year-old little girl that had been found in a swimming pool by her mom and was breathing, but not responsive. And so that was kind of enough that I needed to hear to know that I needed to go get my room ready and call some help. So I also knew that they were already on their way because I could hear the sirens in the background. So a lot of times with these really sick patients, and especially pediatric patients, they'll just kind of load and go because they know that the time is critical to get them to the hospital. So I had limited information, but I knew enough to know I needed my ER physician. I needed to call pediatrics. I needed to get respiratory there. I wanted to make sure I had all my, pediatric size stuff, my Brazil cart, my pediatric crash cart, all of that, because I didn't really know what condition this child was going to be in when she got there. Also, our hospital's really lucky. We have spiritual care. And so I wanted to make sure that I had like the chaplain there because this was, a child and was going to be coming in with mom at least. And we needed to be ready for that to support her as well.
Okay. So based on the report you were given, this patient is or is not intubated already?
Is not.
Okay. It's not intubated and they're bringing in a drowning patient. Mm-hmm. All right. So the patient rolls in the door. What do you see? What's the patient's condition on arrival? What's your immediate priorities?
So as she rolled in, I immediately was like, this kid is really sick. They were bagging her. She wasn't moving around, wasn't responding. And I noticed too, when they were bagging her, I wasn't seeing a lot of chest rise. And so I was automatically concerned that she wasn't getting ventilated. And so I knew we needed to get her a definitive airway and get her some oxygen right away. So when they put her on the gurney, we removed the BVM to assess her airway, see if there was any, water, vomit, anything like that we needed to kind of take care of. And noticed that she even was starting to have some perioral cyanosis. So I knew that we were already like behind the 8 ball that we needed to intervene like really quickly. So.
For sure. Okay, so you see circumoral cyanosis. The kid's not getting good chest draws and fall. Peripherally, how's she looking?
She was cool, pale. I mean, she had been in the water too. So we were already thinking, we need to warm this kid up. Hypothermia is something that we need to address right away as well. And with kids, they've got a greater body area to surface ratio. And so thinking about making sure let's get some warm blankets and things as well. So peripherally, she didn't seem like she was oxygenating, getting that, peripheral oxygenation circulation.
And then when you assessed her airway, was there any vomitus or like that frothy foam that they make from the surfactant and water combo?
Yeah, for me personally, I didn't see that. I was kind of more hearing what was going on. So, respiratory therapy, the doc, they were kind of doing their assessment. And I didn't really hear like, oh, we need to suction or anything, which kind of for me, I was like, oh, but what if there's water in the airway? And I didn't hear them say anything like that. But I know that there is kind of a fine line with suctioning and not suctioning with drowning patients.
Yeah. So that's a really important point. Looking at the airway and considering what is the fluid that we're seeing is definitely going to dictate how we respond to that fluid. If we see vomitus or just like clear water that they've basically ingested into their gut, now they've puked it back up, that needs to be suctioned out. But whenever fluid from, say, the pool or the lake or the ocean, whatever's got in the lungs, mixes with that surfactant, it almost creates like suds. Like the surfactant is really like soap, honestly. It makes the inside of the alveoli nice and slippery, just like a soapy substance would. And so when that mixes with water, you get what looks like foam coming out of the patient's mouth. And again, I'm so used to, if we see some sort of pulmonary edema, suction that out. But what we know about drowning victims is we actually don't want to suction that out. In fact, we want to push it back in. That surfactant is so valuable to the lungs. We don't want to get rid of all of it. And most of what you're seeing is actually air. And they do, in fact, need air back in their lungs. So aggressive suctioning is just distracting from the interventions that we really need to be focusing on, which is getting a definitive airway, ventilating the patient, providing oxygen. So I want to throw that out there. I see this as a common misnomer. We're so scared of the foam. We got to get that out. That is not the priority. The priority is get an airway, get positive pressure ventilations going into this patient. Okay, continue on. So this patient has circummoral cyanosis. They're not looking good. I could ask about what the vital signs are, but honestly, it's irrelevant. Like if the stat is 85 or 35, we're doing the same thing right now, right? We have to get an airway on this kid. Okay.
Absolutely.
So what were your immediate priorities as this patient rolled in the door from the nurse's perspective? I know the provider is trying to get an airway, and what are you doing?
Yeah. So, we definitely wanted to get her on some sort of monitor so that we could see what exactly the numbers were that we were dealing with. I checked a pulse. Honestly, it was kind of one of my
valid,
was my priority too, is because everyone kind of gets so focused on like the drowning and the airway and all of that. And I'm like, do we even have a pulse? And we know with kids too that, respiratory distress and arrest will put them into cardiac arrest. They usually have nice, strong hearts that can just keep going in the absence of any kind of congenital defect or anything. And so I didn't know how long this kid had been without oxygen before she was pulled out of the pool and how well she was really being ventilated on the way in. And so checking for a pulse was my immediate concern while the airway was being handled. And she did have a pulse, thankfully, at that time. And so keeping her warm, getting IV access, getting her on the monitor and really making sure that once we had that definitive airway, that we were able to ventilate her, that those breaths were meaningful, essentially.
Good. And then just from a practical perspective, we always say like, warm the patient up, but practically, what were you doing to warm this patient up? Was she still in her wet bathing suit?
Oh yeah. We got her undressed right away, dried her off,
Good.
Had warm blankets on her for sure.
Okay, good. Yeah, all that's, like these seem like minor things, like, oh yeah, like blankets, but we'll get to blankets later. Oh, no. We're getting the blankets now. Get the blankets on the patient. Yes, very good.
Yep, absolutely.
Okay, so you're warming the patient, you're getting on the monitor. The other thing I was wondering, you said you checked a pulse. Was it tachycardic or was it bradycardic? Because that kind of gives me an idea how much time we're working with before we lose a pulse.
Yeah, she was fairly tachycardic initially when she came in, but weak pulses, they weren't like really bounding, they weren't strong, good pulses. So it was something that I continued to check. Okay,
so then as the case is unfolding, like what stood out to you as far as like the severity of her respiratory impairment?
So once she was intubated, of course we had her on the end-tidal CO2 through the vent and SpO2 monitoring and all of that. And one thing that, I noticed it was very hard to get her SpO2 up. Ideally we wanted it between like 92, 96%. And she was very difficult to ventilate. It seemed like, because of all of those things that happen physically with the lungs and like you were saying, the surfactant and alveolar collapse and those kinds of things, it was just, she wasn't getting that good gas exchange. And we kind of felt like we were a hamster in a wheel. Like all these things that we were doing, it wasn't really translating.
I wanted just to kind of echo that a little bit. So many times I've had a patient who's crashing and my heart just wants to like, get the intervention, like get the tube in, thinking as if some plastic tube in an airway is going to fix things. Maybe for anaphylaxis, okay, maybe we can keep the airway open with the tube. But for like every other patient, the issue is actually much lower than where the tube sits. And so just because we got the airway in, I cannot take a sigh of relief just yet. This patient is still critically ill. In fact, once the airway's in, okay, now the work really begins. How are we going to optimize the patient now that we have this great resource of the airway? And as you said, the airway went in and her SATs did not come up, which is very concerning. So as far as documentation goes, what type of verbiage are you using when documenting? How are you describing this patient in the record?
Yeah. So, initially when she came in, she was brought in by ambulance after an unknown submersion time in a swimming pool, kind of going back to what you had said at the beginning about the way that we classify these situations. She was a severe non-fatal drowning at that point because she had not passed from the drowning initially. So the severe non-fatal drowning would be how I would have described her. And then, of course, you document all your interventions. And then, like you said, airway is always going to be your first thing, right? You're going to get an airway, but right after that is breathing and ventilation. So you have to assess immediately, like, did this airway, is it working? Are we getting, that good chest rise and fall? Are we getting a good color change? Are we having stats come up? And, that's like you said, it's a much deeper issue than just throwing a tube in and securing it.
Yeah. And this patient, she had never lost a pulse that we're aware of, correct?
That we're aware of. Yeah. And that's actually
Okay.
one thing. It had been kind of a question from EMS on the way in that they had said, we think we had a pulse the whole time. And so that was one of the things that would made me like, let's check a pulse right now, make sure we still have one. And I never fault my EMS providers with what they do out there. I mean,
Right.
especially in these situations where, the adrenaline is just insanely high and the stakes are high, especially when you've got, a pediatric patient. And when you're in the back of an ambulance and you're driving code through to a hospital, I mean, you don't know what you feel or what you see or what you hear sometimes. And so I've done that. I've ridden out with them before, so I know how it is. So to my knowledge, we had not lost a pulse. Looking back on it now, knowing, the outcome of our resuscitation attempts and everything, it's possible that she had at one point, but I mean, we don't know for sure. Yeah.
Yeah, we'll never know. Yeah. I mean, this is probably a good time just to mention another quick, misinformation that's out there. The whole hands-only CPR campaign has been very helpful in encouraging bystanders to do CPR on the general population. People are so scared to do mouth to mouth, and so they just wouldn't do anything. So they're like, hey, lay people, you can just do hands only. It's better than nothing, right? I will say that applies to everything except for drowning, because if someone is pulseless from a drowning incident, we can do all the hands-only CPR we want. What they actually need is ventilation and oxygenation. And so hands-only CPR are going to get you nowhere with this patient population. So yes, if their pulses, do compressions, but you do have to do mouth to mouth if you don't have a BVM close by, or there's no hope of survival. So You make a great point. Maybe she was pulseless at some point. Maybe she wasn't getting good ventilations for a while, and that might have led to the unfortunate outcome that you faced. Okay. Back to the case and back to the physiology. Can you kind of break down what's happening at the alveolar level from a drowning incident?
Sure. So you had mentioned earlier about the surfactant, that kind of foam froth that we may see in the airway. So there's this phenomenon called surfactant washout. And so when there's a lot of water that enters the lungs, it can actually wash out that surfactant. And that surfactant is really important lining in the alveoli of the lungs that helps with gas exchange. It helps keep the alveoli from collapsing. That surfactant helps keep the alveoli open. And so when that gets washed out, the alveoli can actually collapse in on itself. And so when you have that in such a wide spread area, you don't have any way to have that gas exchange and to oxygenate. So hypoxia, is the result.
Yeah. And then what about pulmonary edema? I think maybe early in my career, I thought that pulmonary edema was just because there's water in the lungs from the pool, but it's a little bit more than that.
Yeah. So the lungs have an alveolar capillary membrane that kind of keeps air in the alveoli and keeps, that protein-rich fluid on the outside. And so when there is injury or illness or inflammation to the lungs, that actually causes swelling, right? Inflammation is a fancy word for swelling. So when things swell, they kind of get bigger, and that membrane opens up and allows more room for those bigger molecules, those solutes and those protein-rich fluids to kind of make their way into the alveoli. And then you've got fluid in the lungs, and that makes it harder for the oxygen to move through that area and get out into circulation.
Good. So it's not just the water that they ingested, it's the water that is almost third spaced from the vascular system into the alveoli. So it's a double whammy.
Exactly.
As far as making it difficult for gas exchange. Okay.
Yeah. And that's why too, we don't typically give diuretics to these patients, because it's not like they're in fluid overload. It's just the fluid's in the wrong spot.
Right.
And so that's where you need just that good PEEP, right? Positive pressure to keep all of that open and push the oxygen through all of that fluid that's kind of creating a barrier.
What did you see was the biggest challenge for maintaining oxygenation and ventilation in this patient?
So I think, and I'm not a respiratory therapist. I never have claimed to be one. I am an ER nurse, so I usually phone a friend when it comes to vent stuff. I'm like,
Yeah,
hello.
as you should, right? That's why they're there. It's a collaborative, interdisciplinary effort for sure.
Exactly. I love my specialists. So I know that it's a fine line to walk between giving the high PEEP, and with kids too, you tend to want a higher respiratory rate as well. And so having all those things increase while keeping a lower tidal volume, because we didn't want to cause more trauma. We didn't want to cause more trauma to the lung tissue and to the alveoli from, having that large volumes pushed in and causing the alveoli to open up and collapse and open up and collapse. And so those can actually cause more trauma. And so kind of finding that balance and making sure that our interventions were effective, it was very difficult.
Before we talk about the outcome to this patient, I wanted to also briefly mention a lot of patients, like drowning victims, they actually do okay. Like they start coughing up and they never lost a pulse. Maybe they got a little bit of rescue breaths and then now they're, pinking up for us. But sometimes we still bring them in for monitoring for about 8 hours. What are some of the reasons we do that, for one? And then what are some of the subtle signs that a patient is worsening that nurses should be watching out for these non-fatal drowning victims?
So like we talked about before with the inflammation, those things can kind of develop over 24 to 48 hours. So initially, you've got someone who's coughing and they're like, okay, I'm fine. There's no more water in my lungs. Well, the damage has been done. And so from that, injury to the lung tissue, the inflammation can kind of happen over time and allow, like we were talking about, those protein, that fluid shift. So that phenomenon can develop over time, which is why we want to monitor people after a submersion incident. Things to look out for, are really going to center around your respiratory assessment, right? So crackles in the lungs, decreasing SpO2, obviously like any type of cyanosis is going to be a late sign. Even altered mental status from people, just not having the good oxygen circulation to the brain. So little things like restlessness and anxiety and that kind of thing can clue you into a deteriorating respiratory status as well.
Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode.
I wanted to add a couple more. Increasing oxygen demand. I think as ER nurses, we're so used to just adding more oxygen when we see the stats low and just moving on with it. But if you went from no liters to 2 liters to 4 liters to 6 liters, okay, why? Yeah. Why are they needing some more oxygen? We should be sounding the alarm for that, not just fixing it and moving on. And then the other one, and you kind of mentioned this, with pediatric patients, what's their mental status? Are they becoming fidgety, antsy, or worse, somnolent, not responding as much to us? All those things are going to tell us so much about the patient's status. I like to call it the inflammatory cascade of awfulness that ensues. And so, yes, I have seen patients look fine initially until the inflammatory cascade kicks in, trying to help things, ends up making it worse. And now there's more fluid rushing to the lungs. And now we do need to do an airway intervention. They didn't need an airway before, but now they do need something. Not all patients that seem fine initially are going to be fine. So we don't send them home necessarily until we've watched them for a good chunk of time.
Yeah, I've actually seen too, because I live near the ocean too. So we get a lot of, adults that think they're going to be surfers all of a sudden or something. And so, they come in and they've gotten tossed around and they seem okay initially. And we'll even maybe put them on a CPAP or a BiPAP for a short period of time, just to make sure that we kind of push through those, alveoli and keep those open and just give them that little extra support. So
anything else you want to talk about before we kind of pivot and talk about the emotional aspect of caring for this patient population?
I don't think so. I think that sometimes it's easy for us to get focused on what we're doing because we know we need to intervene quickly and that's our job. And
yeah, it's important.
And so we tend to forget that there, might be a family member in the room or something that they need to be taken care of too. And that's especially true with pediatric patients, designating someone for them.
For sure. And yeah, thank you for reminding us of that. It's such a hard spot to be in as the nurse where you feel the sadness coming from these parents and you want to care for and nurture and support them, but you also feel the need to be present in resuscitation. And so having the resources of the spiritual care team that you had mentioned, or just a nurse is designated just to the family. I mean, even the unit clerk, someone just to be with the family so that the nursing team, the physician team, the respiratory therapist can focus on the patient, but the family is still important too. So not forgetting them or pushing them aside, even worse, including them in this whole resuscitation effort.
Absolutely.
Okay, so let's talk about this case. Walk us through the rest of the story. What ended up happening with this patient?
So we basically were never able to really get her adequately ventilated. Unfortunately, I think that the damage to her lungs had been so severe and widespread. And again, we were not really even sure how long she had been in the pool. And so when she came to us, I think that we were already, like I said, kind of behind where we needed to be. So unfortunately, she just continued to deteriorate and we weren't able to resuscitate her. She ended up going into cardiac arrest and we never got her pulses back. And so it was a long day too. It seemed like everything seems a lot longer when you're kind of in the moment, but it happened over a couple of hours, a few hours. And it's like we had hope that we were going to be able to turn her around. And so when the reality kind of struck us, it was like getting hit by a train. And, it's just that kind of feeling that, we did everything we could. We did everything right. And the outcome still wasn't, what we wanted it to be, what we worked hard for it to be. And just kind of that reminder that we don't know. We don't know how long anybody has. This was a 2.5, almost 3-year-old child. And when that happens, it doesn't seem fair. It doesn't seem right. But having that kind of reminder that there's only so much we can do and we don't always have the outcomes that we want.
And especially being the primary nurse, it is, I feel like the weight is even heavier than whenever you're just jumping in to help your buddy, whenever it's this is your patient. And I think as ER nurses, often we receive coding victims and maybe we can't get them back and it's sad, but this is a patient you've cared for hours now and you got the tube in and you had hope and then now she's declining. It is all the more of an emotional roller coaster and difficult to process. And I have had cases like this and I can almost still hear the mother's wails whenever you tell them that there's no more hope, that we can't continue to resuscitate. That is even, years later, I still feel that. So walk us through, how was it for you and your team whenever you guys called time of death? How did that go down? Did you debrief? How did you process it personally?
Yeah, I know that sound that you're talking about. And I think that, anyone that's heard it knows that it never goes away. And I'm a mom. So you feel that kind of on both sides. You feel it as a clinician and you feel it as a mom, as a human being, right? So afterwards, we did debrief for as much time as we kind of could. And I think debriefs are amazing. I don't think that we do them enough, honestly. We always do them with a pediatric code, but not every time with an adult, which I think we should. But we learned some things that we probably, could have been better, or, some conversations with teamwork or communication and all that thing. We can always improve on things like that. But at the end of the day, I still have 3 patients to take care of. And so as much as I had shown up for this child and her family, and I had done everything that I could as a nurse, as a clinician, I needed to do that for the new patient that I had in another room of my assignment. And so nurses and across the board, and especially like ER and ICU nurses, we're really good about compartmentalizing, right? So we take these situations that are really heavy and we put them in a box and we close the box up and we put it on a shelf to kind of deal with later. Because I've got to continue on in my day, and I can't let this affect the way that I show up for my other patients. And so after years of these really heavy things kind of happening and putting them on a shelf to deal with another day, which, I mean, personally, I can only speak for me. I was never really good about taking them back off the shelf, right? And kind of processing it. And so you stack all these things on a shelf over years and years of nursing. And then that last heavy box that goes up there just causes the whole shelf to come crashing down. And honestly, this case did that for me. I remember just crying the whole way home. When I got home, I was upset. I was sad. I don't think I can do this anymore. We did everything right. This isn't fair. This is not how it's supposed to be. It's when you have those times where there's just death after death, and there's illness and there's trauma, and, someone gets diagnosed with a new onset disease and you're like, why is this happening? And it's more negative than it is positive sometimes. You're just kind of think, why am I doing this to myself? I wasn't able to show up for my family. I was not able to sleep. I didn't want to go to work the next day, and so for me, it was a kind of a breaking point, and I had to take a look in the mirror and say, what am I doing? And can I keep doing this? And I know at my core, I'm a healthcare provider. I want to take care of people. And I needed to kind of figure out how to make both things be true. It's okay to be human and it's okay to have these feelings and emotions, but I have to be able to do the job as well. And I remember having a conversation with my boyfriend, and I was like, I don't know how to handle this. I don't know how to not get past it, but get through it and have it be something that I learn from, but also that, I can move on from. And, very sweet, he's a software engineer, so he does not live in this world at all. But he's just kind of like, well, maybe just talk to a therapist, or, well, you guys debriefed afterwards, right? Or how about a Headspace or Calm app, or, that kind of thing. And which I've done all of, by the way, and nothing really felt connected to the actual situations that we go through as nurses, ER nurses, critical care nurses. So we stayed up almost all night that night talking about how we could potentially not fix the problem, but help nurses in these types of situations kind of decompress and have an outlet to have a restoration in their love for the job. Burnout is something that is a known thing that, nurses are going through. People are leaving the profession because of it. It leads to compassion fatigue, all these things. And so we really just kind of started looking at, is there something we could do about it?
I wanted to go back to that just for a moment. You used the very appropriate analogy of putting in a box and putting it on the shelf. I have had to do that so many times in my career. Like, okay, I know this is heavy. I need to address this. I can't right now. I'm just going to set it over here and come back to it later. How your hindsight wisdom, now that you are like, you've worked through this, you've learned resources, how do you go back to that? How would you recommend that nurses take those boxes back down and unpack them? That doesn't feel good. I'd much rather just keep it over there and move on with my life. Talk me through the importance of taking that box back and reopening it and working through it.
Yeah. I mean, it's like any other kind of type of trauma, right? When something bad happens, you want to run away from it. You don't want to have to deal with it and, kind of address the impact that it's had on your life or your career. And so there's a lot of ways. And in this app that we've developed, we've taken a lot of things that therapists and, coaches will kind of advise people to do, like journaling. Journaling is something where you can get it out and, having just kind of that social support, listening to meditations, things that really kind of resonate with you, and really allowing it to have happened, not to you necessarily, but just you being a part of something that has happened. And yes, you had a role that you played in it, but that situation, that patient doesn't define the rest of your career. And to kind of go back and remember that day, yes, I had that situation happen, but I also helped a lot of people.
Yeah.
I splinted and I gave pain medicines and I, educated on a new onset diabetes. And I did all of those things as well. And so to remember that, there is positive in this job, and to try and have the respect and the feelings for the things that are sad and that don't, go the way that we would hope they would, but to remember all the times that it does, and to give those things as much, I think, space in your brain as the other things.
Yes. I like to call that facing the hard stuff and celebrating your wins.
Mm-hmm.
The hard stuff is we just lost a 2.5-year-old. That is hard. Like, call it for what it is. Don't ignore it.
Mm-hmm.
But I also got to bring pain relief to someone who
Mm-hmm.
is hurting, and split someone and get them home, and teach them about their diabetes, and, connect with the patient, who was scared, and like support them. Like, I did so much good today. And so taking time to reflect on those, I would say, is just as important as processing the challenging, heavy, hard things that we face. Can you explain how the app helps with that processing?
So it's called Get Vitals. It's something that nurses do all the time, right? We get other people's vitals, but what are my vitals? So it's called Get Vitals. And it is a mental health app made for nurses by a nurse.
Mm-hmm.
And so there are post-shift reflections in there that you can kind of listen to on the way home, which I really recommend.
Oh,
this was my favorite. This is my favorite feature in the app, because a lot of times, we tend to bring work home with us, and you get in the driveway and you're like, I don't even think I can go in and show up for my family right now. I haven't, processed or left that other stuff behind. So having these guided meditations, and there's different categories. It's, there's one for when you did lose a patient, or when you had a difficult interaction with a family member or a coworker, meditations to remind you why you started, and when the shift was overwhelming, and all these things that you can kind of choose. Like, this is what my day was like. I want to listen to this one. And so that really has helped me personally doing that. And then I feel like by the time I get home, I'm like, okay, I'm ready to be Amber now, not Nurse Amber. So that's been really great.
Yeah. So it's like it guides you in opening that box.
Absolutely. We talked about like the journaling aspect. And so there's a spot where nurses can give advice or, share a little story. Like a patient drew me a picture the other day, and I had a little pediatric patient, and she drew a picture of me and her. And those are the little things that are the positives and the wins. And so having that opportunity to journal it helps with the nurse, but it also, like I said, we're caregivers, so we want to help other people. So if I'm able to journal this and think, oh, somebody else is going to get something good out of this, it helps both of us. And so it's really a win-win. And then to be able to kind of scroll through that on, the homepage and see all these little wins and good advice and things like that is really helpful. And it gives you that social connection. It's not a social media site where people can just post whatever they want and, it can be negative and all that. It's very regulated to be positive and encouraging, but it does remind you that you're not alone out there. And there, you have a tribe that is, maybe going through the same things, and this is how they're handling it. This is how they're dealing with it. And maybe I can try that so that, I can lessen the weight on that shelf that I've got.
That's good. That's good, Amber. Okay. So for the nurses that are listening, they're like, you know what? Amber has a point. I have been just putting those boxes on the shelf. I need to do something about this. How could they find this app?
Yeah.
How does it work? Because I do think it's a valuable resource, because gosh, we don't learn this stuff in nursing school. We learn how the pathophysiology of the drowning patient, but we don't learn how to process the sadness whenever all of our interventions don't work. So I love that there's resources like this, which is why I have you on the podcast. You just talk about how a nurse would find this, and then how they would actually use it on maybe a daily or, depending on the shift, whenever it's needed kind of situation.
I love that you said they don't teach us in nursing school, and you're so right. It's just, you don't learn how to deal with the real stuff, right? And I think that sometimes the resilience trainings or the things that we try and have offered to us is, in my opinion, nurses are already resilient. If you can deal with blood and bones and all these things, like, your baseline resilience. We don't really need to be trained how to be tougher. we need to be able to process these things. And so you can find us on the App Store and on the Google Play Store. So we're on both platforms. Our website is getvitals.care, and it's got a ton of information, ton of resources on there. And, my boyfriend and I were trying to kind of market this to hospitals, like hospital leadership, like, hey, you should get this for your nurses. It'd be such a great thing that would help with your turnover regarding burnout and all of that. And it was just a very, very hard shell to crack. And so we've pivoted recently, and we are giving it away for free right now to nurses. So it's really, you can't lose. You can download it on, like I said, the App Store, the Google Play, go to our website. And it is one of those things where you'll get like little reminders during the day. You'll get a reminder to take a burnout assessment, so you can kind of see, am I in the green or am I in the red? And what kind of, do I need to do to help get this burnout level down? It gives recommendations for, meditations to listen to. It'll tell you what, maybe, 3 other nurses listened to this today. You're not alone, and things like that. So it's really interactive. Yeah.
So you're literally like taking vitals on yourself and then responding to the changes in your vitals with interventions that are evidence-based.
Absolutely.
I love it.
Absolutely.
Definitely built by a nurse. This is definitely built by a nurse.
I know.
I love it.
But it's really pretty and fun too. So that's where the software engineer came in.
Okay. I love it. I love it. Well, Amber, thank you so much for sharing your story and being vulnerable. I wanted just to close with a couple takeaways. What would you say are the main takeaways, both from a science of nursing perspective and a heart of nursing perspective?
Sure. I think the science of nursing is to remember, even though we are expected to know all of these, pathophysiologies and treatment modalities and, interventions and skills, is to remember it's okay to be human as well. And that really, that is the heart of nursing. And you bring that compassion and that vulnerability that helps, make patients feel like they're going to be taken care of, and that they've got someone, kind of looking out for them and on their side. And that caring is really what the heart of nursing is. So it's okay to be human, be vulnerable, while also being an amazing clinician.
I couldn't have said it better myself, Amber. So in summary, Amber has reminded us that while we must understand the science, the alveolar injury, the surfactant washout, the pulmonary edema, all the evidence-based interventions, we also need to prepare for the emotional reality of these cases, especially when we lose a child. As nurses, our role is critical. Rapid assessment, anticipating interventions, clear documentation, using the right terminology, supporting both our teams and families through some of the hardest moments they'll ever face. So yeah, Amber, thank you for sharing your expertise and your heart and being vulnerable and honest with us today. And thank you, listeners, for committing to this work. Not just the technical skills, but also the resilience and compassion that make nursing what it is. So, Amber, thank you again for your time.
Thank you.
And until next time, keep showing up, keep learning, keep checking in with yourself. This is difficult but important work, and your presence matters more than you know.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsrn.com
or on all social media platforms as the Rapid Response RN.